Okay. So, in today's class, we will discuss about the approach for confusion, and I already discussed the points we need to cover um, in a long clinical consultation. I am reviewing the points again. So we used to in first point we used to introduce ourselves and then ask about the presenting complaint, what brought them to the clinic, uh, and whether they're having any other symptoms. We need to explore the symptoms, and we need to find out our diagnosis. We need to find out the cause of our diagnosis, associated complication. We need to exclude the differential diagnosis and the red flags. And number five, we need to analyze the corresponding symptoms, system analysis. Like in a case of headache, you need to explore the neurological system first and then go on. And in number six, we need to explore the PMFP, the past medical condition, medication history, family history, and 3P for female, the pill, period, and pregnancy. And number seven is the system analysis. And number eight is the mood, diet, travel, and sexual history. Number nine is the social history, the smoking, drinking, living, and impact of the symptom in their daily life. Then we need to summarize the case. Then we do need to examine the patient, ask about the concern, explain the diagnosis or differential diagnosis, ask about the investigation, specialist involvement, giving decision about admission or observation, whichever is needed. We need to explain the patient what they need to stop and what they need to start. Like sometimes some symptoms may directly related to the medication. We need to stop that medication. So, in today's class, we will discuss about the confusion. Confusion is a very important topic, uh, which is very common in a long clinical consultation, specifically the Indian centers. So, for for the confusion, we can divided the confusion into three categories. Number one is a transient episode of confusion, um, and number two is acute confusional state, which is not transient and lasted for a short period of time. And number three is the chronic confusional state, which we label as a dementia. So for acute confusional state and transient confusion, we have some differential diagnosis, and for chronic confusion, we have another sets of differential diagnosis. So for transient confusion, we have four differential diagnoses. The number one is the transient global amnesia, which is a benign condition. In this condition, the patient used to develop a brief episodes of confusion, where they cannot form any new memories, and repeating the same question. And this is usually a very benign condition, and this is very commonly appear in patients exam. And number two is the transient ischemic attack. Number three is hypoglycemia, which is always a differential diagnosis for any confusional state. And the number three is the transient epileptic amnesia, which where confusion is related to epilepsy. And number two is acute confusional state. We call it delirium. For delirium, there is a there is a definition for delirium. It's a fluctuating level of consciousness. The consciousness will vary throughout the day. Sometime it will improve, and sometime it will get worse. And uh, patient will find very difficult to focus, or there will be inattention. They may be get violent. There may have some aggressive behavior, and there may also experience some hallucination in the form of auditory and visual hallucination. And you need to ask all these question: is this confusion fluctuate? Is this by this question I means, do you think it's improved sometime or getting worse sometime? And do you find any problem with focus, or do you have you experienced any aggressive behavior? So ideally, you need to take the history of confusion from, not from the confused patient, but from the attendants. So the scenario will be like this: talk to the sister or talk to the wife, whose husband is confused now. So you have to explore the history from the attendance of the patient or relative of the patient. So you need to explore the whether they see or hear abnormal things. You need to exclude the auditory and visual hallucination. And you also ask about the past memory problem, because the patient who have dementia are very prone to develop delirium. So for the causes of delirium, I remember it by M vitamin DM, uh, M vitamin DP, M vitamin DP. So M stand for metabolic. The metabolic is very important. It's invariably associated with confusion. So for all cases, you need to exclude the metabolic causes. So for metabolic causes, we have hyponatremia, hypercalcemia, hypoglycemia, hyperuricemia, uh, which we call uremic encephalopathy, and hepatic encephalopathy. These all are very important. And for V is for vascular. We have stroke, and I stand for infection, which is a very common cause of delirium in a elderly patient, like pneumonia, urinary tract infection, sepsis, meningitis. T stand for trauma, tumor, and D stand for drugs. Drug history is very important. Drugs and alcohol. So in PACES exam, lithium is a very important drug. Sometime patient might have some mood disorder, and he's taking lithium for a long time and now develop confusion and some tremor. So you need to exclude the lithium toxicity. Antipsychotic medication and alcohol. Alcohol can cause confusion. That's a very important history to explore. So we also have post-ictal confusion, which where the confusional state is associated with the epilepsy. So you also have a chronic confusional state. We call it dementia. So if you have a patient who is having forgetful last 3 months or more than 3 months, 6 months, so there is a very high chance this patient have memory problem in the form of dementia. So you have to explore the duration of the problem, whether this problem is gradually worsening, and difficulty finding words, naming objects, recall, difficult to retain the information, and about the mood, alcohol, head trauma. So for dementia, we have some differential diagnoses like Alzheimer disease, Parkinson disease. Parkinson disease, in a patient with Parkinson disease, dementia is a late feature, but the Parkinson plus symptoms where the dementia is an early features, like Lewy body dementia, um, other form of dementia like frontotemporal dementia, subdural hematoma, which associated with head trauma, Huntington disease, normal patient hydrocephalus, and the very important things are the reversible cause of dementia, which you must need to exclude in every patient who have memory problem. So you need to explore whether their uh, whether explore their mood, because depression can mimic dementia. There is vascular dementia. Repeated stroke can cause dementia. We call it vascular dementia. Vitamin B12 deficiency, alcohol, the Korsakoff psychosis, and hypothyroidism. These are the reversible causes of dementia. So our case was, let's discuss our case. So our case was, the patient was having, um, so our case was, the patient was a case of chronic kidney disease who received renal transplantation 1 year back, and now now he developed confusion for last 2 days. So in this case, we have uh, we divided the skills into several parts, and examiner want this skill to be fulfilled by you. Like in clinical communication skill, you need to explore the possible causes of confusion to that patient. In that case, the main issue was patient was having um, some problem with their micturition, problem with their water work in the form of burning sensation, high color urine, and low volume urine. uh, because when you further explore it, they will the patient or patient attendant will say to you that for last few days he take less amount of food and water, drink less amount of water. And another area of is there, the uh, medication side effect which can cause confusion. That patient was taking immunosuppressive medication in the form of tacrolimus. So you need to explore the other side effects of tacrolimus, like tremor, hypertension, hyperglycemia, and ask them about the create kidney points. So do you know your last kidney point? For physical examination, we you need to examine the patient neurologically, because this is a case of confusion. At least you need to take. You can start at your examination by seeing the tremor or any flap. In case of uremia, in case of hepatic encephalopathy, we invariably have flapping tremor. So you need to take that. You need to look for any shakiness in the hand, and then you can go for the neurological examination, like taking the power plantar examination. And you must need to ask the examiner that you want to evaluate the patient with mini mental state examination. So some of the component of mini mental examination you need to ask to the patient. So uh, whether they are oriented with time and place. So could you please tell me, is it daytime or nighttime? And what do you think? Is it day or night? And place? Could you please tell me where you are now? And you can ask to naming some object. You can ask him to recall any of their significant life event. So when you explore these three questions, examiner will know that you are exploring the component of mini mental state examination. and you need to ask for the abdomen examination because this was a case of renal transplant. So you need to expose the patient. You need to look for the any tenderness, any bruise. Tenderness may indicate there is some problem with renal transplant, but in our case, the abdomen was non-tender. So for differential diagnosis, so we in that case we have some differential diagnosis like um, confusional state is labeled as delirium. The underlying most probable cause is urinary tract infection, which is a very common cause, and other differential diagnosis is electrolytes imbalance. Hyponatremia can cause confusion. And for clinical judgment, you need to give a clean plan to the patient that we need to arrange urinary examination to find out the infection, and we also need to check the blood salt level, and we also need to start the antibiotics because I am suspecting you are having waterwork infection. For concern, that case I have specifically two concern: whether my transplanted kidney is functioning well, and do I need treatment urgently. So yes, you have to reassure the patient that the kidney transplant is functioning well. And for the investigation, yes, you require investigation as early as possible, and I will do a strict test, urinary test, strict urinary test, deep strict urinary test, and I also give you some medication in the form of antibiotic to resolve the infection. So welfare, you know it. And so that was our case, and this type of case are common in Indian centers because sometime they may have shortage of cases, so they will give the clinical case in long clinical consultation, and you need to explore that accordingly and find the appropriate diagnosis, differential diagnosis, and management plan for that patient. Thank you very much.